Well, hello, everybody. Welcome back to another week of HeartBrief. I'm Joel Kahn, medical doctor, clinical professor of medicine, and triple board certified cardiologist back in the Great Lakes State of Michigan. That's why I don't have a palm tree behind me. Well, we've got three super powered and important articles this week that may help shape your practice. Let me start with perhaps the first low key one, but still one that generates some controversy. Extra virgin olive oil. Should you follow a no oil diet? Some do. Should you follow a beef tallow diet? Bobby Kennedy Jr. is teaching that. Should you follow the Mediterranean pattern with extra virgin olive oil? So, in Clinical Nutrition, ESPN, just published here in February 2026, February 16th, or accepted on that date, is a systematic review and meta analysis of extra virgin olive oil in individuals with mild cognitive impairment and dementia in older adults. They were able to find 5 studies that actually did a randomization, 747 participants overall. They had evaluation that led to a clinical diagnosis of MCI, mild cognitive impairment, or actually mild dementia. Meta-analysis showed a significant, although they concluded preliminary, improvement in global cognitive function scores with extra virgin olive oil consumption. Also, this applied to those that actually had the diagnosis of early Alzheimer's disease. The overall pooled effect was small, but still the trend was clearly favoring that if there's going to be an added fat in the diet, extra virgin olive oil goes for the win. The conclusion was the finding suggests a potential association between extra virgin olive oil consumption and improvement in global cognitive function amongst older adults with MCI and dementia. Due to the low certainty of evidence, small sample size, and lack of established clinical significance, these results should be interpreted with caution and larger RCTs are required. The usual statement that comes out of studies like this. A study came out of Brazil, Yale University, and University College in London. So I think as we teach patients about nutrition, and we must teach patients about nutrition, as you may have seen, there's a movement to include 40 hours of nutrition education in medical schools that's being proposed. Hopefully will be passed, but there's already a controversy. What is that education going to be? Is it going to be the carnivore diet and beef tallow? Or is it going to be the more conventional Mediterranean diet, mind diet, vegetarian, plant-forward diet? We'll see, but we must teach education, and there's no doubt drizzling some extra virgin olive oil of high quality in a glass bottle, hopefully with even a date when it was harvested, so you know that it's within 12 months, which is optimal, actually, because there's quite a bit of loss in polyphenols in olive oil over time. It's unlike wine. We know that wine can mature and actually improve in quality over time. Olive oil is the opposite. All right, let's go to article number 2. We'll save the big one for last. Article number 2 is a pure cardiology article. And let me pull it up myself. I'm making it difficult, but there has been a study called the SCOT-HEART Trial. And I think you see it. I see it now. And this was a prospective study of using quantitative coronary CT angiography in people with chest pain, in large numbers of people, several thousand, and looking at the utility of coronary CT angiography to make accurate diagnoses. But in a sub-study published in European Radiology, again, just published within the last few days, is the development of coronary disease in patients with an initially normal coronary arteries in the SCOT-HEART trial. Most of the researchers are from Europe. So out of the original sample of thousands of people in this study, they identified 524, mean age of 53, 38% male, that were judged to have normal coronary arteries on that first study coronary CT angiogram. They looked at who had a follow-up CT angiogram in the next 9.3 years, and they identified those that had a follow-up study. Now, they may have had a follow-up study, usually for clinical indications. It wasn't part of the protocol to get a follow-up study. And what they did is when they looked at this, I'll give you the bottom line overall, is about 1/3 of those that had a judged to be completely normal coronary CT angiogram within 10 years now demonstrated coronary atherosclerosis. 1/3. If you look at where it says key points under findings, among the 524 patients with normal coronary disease was identified in 48% of those that underwent a complete coronary CT angiogram, and 25% who had a chest CT, but somebody looked at their coronary arteries and identified calcification. During the 10 years of follow-up, overall, it was 1/3. The clinical relevance, a substantial portions of patients with initial normal coronary arteries on coronary CT angiography later developed coronary disease, highlighting the need for clinicians to be alert for the development of new coronary disease, even with initial normal coronary arteries. So these patients were 53 when this study was done. They were, up to 63 years old by the time the follow-up was being done, just on average. In my clinic, if you have a calcium score of 0, I follow what is reasonable literature. You're going to get a repeat calcium score in about 5 to 7 years, rarely earlier than that if there were extreme risk factors. Very high LDL-C, very high ApoB, very high lipoprotein A, or some other issues, type 1, type 2 diabetes, might go more towards a 5-year follow-up. If somebody has a very abnormal calcium score, I don't repeat it. It's always going to be higher. And then we're learning what to do with a normal coronary CT angiogram. Maybe again, 5 to 7 years later, it might be worth a consideration of a repeat imaging study of some kind. But the trend more and more is if you're having a chest CT, artificial intelligence softwares are now FDA approved to analyze the chest CT done for a pulmonary indication for coronary calcification. So when this becomes routine, this is going to be quite a breakthrough, okay? Well, let's go to the big one of the week, the one that's gotten headlines all over, just released in the last few days. Certainly too long to go through every facet of it, but in the journal Circulation and also in the journal American College of Cardiology, published in both the 2026 guidelines on the management of dyslipidemia. And many, many cardiovascular societies and diabetic societies were involved in this, as you can see, all the abbreviations. But a very prominent group of researchers, excuse me, you can estimate maybe 30 of them, names that you see in the literature all the time, academic, respected people, did review the entire literature in the world to provide this update. I looked before, I'm forgetting now how many hundreds and hundreds of references there are at the end. And the last time this was done was actually in 2018. So this was a major update. And just to tell you, if you want the big 5 selected key takeaways, they include, number 1, test and treat early. So even at age 9 to 10, check cholesterol for that 1 in 250 that has heterozygous familial hyperlipidemia. By age 18, check cholesterol again and check lipoprotein A and check lipoprotein B, ApoB. Number 2, they call it CPR, calculate the risk with the prevent risk score, personalize based on your interview with the patient, and then consider a coronary calcium score in a young to middle-aged adult to reclassify and reassess risk. R for reclassify. Number 3, use the prevent equation. Number 4, target LDL and non-HDL thresholds. LDL is the target. Number 5, be sure to measure apolipoprotein B and lipoprotein A routinely. And let me give you some more here. There are more takeaways. Test and treat early young adults. Should be tested, screened with a lipid panel at age 9 to 11. Again, age 19 to 21, and then every 5 years. Begin behavioral counseling, nutrition counseling, and consider, this is controversial, prescription lipid-lowering therapy for young adults with LDL cholesterols over 160 and a strong family history of coronary disease. Number 2 is the CPR, calculate, personalize, reclassify, reassess. Number 3 is the prevent thresholds. Number 4, the LDL goals are back. And those with established advanced coronary disease, the LDL cholesterol goal is less than 55, which is what we do in my clinic. Lipoprotein B, less than 55 is a very good goal in those with established coronary disease, less than 90 for those overall. Lipoprotein A, check at least once in everybody's lifetime as early as possible. Next is the coronary artery calcium score, age 40 and up for men, age 45 and up for women, can really help in reclassifying risk. Number 6, I think I'm up to primary prevention of LDL lowering therapy. We are talking about statins, low dose ezetimibe, if not tolerated, bempedoic acid and PCSK9 inhibitors and new agents. Number 7, secondary prevention LDL goals, LDL less than 55, and those with established coronary disease may require adding on ezetimibe, bempedoic acid, and PCSK9 inhibitors. Number 8, triglyceride matters and levels above 150 are associated with the risk, should be addressed through nutrition, exercise, weight loss, and if needed, pharmacotherapy. Summary, we must implement these clinical pearls into practice and work hard to bring down cardiovascular event rate. So I encourage you to look up this massive document, over 100 pages, I believe, and see how it fits into your practice and see indeed if we can make a dent on this awful burden of atherosclerotic coronary artery disease that we have going on. So thank you again for being here today with me on HeartBrief. It's an exciting week this week. We'll see you back next week, hoping for spring to come soon to the Great Lakes State.